That's great.
So I'll get started. My name is Karim Osman. Actually, Dr. Neil Sika is my PI. I'm a medical student at George Washington University, and I've been very happy to work between GW MFA and Unity Anacostia for the last 2 years while I have been a medical student only. So it's been a great part of my education. The name of this presentation is Improving Specialty Care Access via Telemedicine, ISCAT for short. And you'll see you can go to the next slide. It's a collaboration between Unity Anacostia and the MFA, Medical Faculty Associates for George Washington University, to provide telespecialty care for Unity patients without them having to leave their primary care clinic. So just some background, even though Washington, D.C. has the second highest insurance rate in the country, there exist many barriers to providing specialty consultation in underserved populations. So what we seek to do was to augment or replace conventional specialty consultation for a number of reasons. Number one, the specialist at the federally qualified health center, it's very hard. They don't deal with enough referral volume, number one. Number two, there are high no-show rates for patients going to the federally qualified healthcare facility. And number three, there's inconsistent scheduling. So that's why it's difficult to have a full-time specialist stay at a federally qualified health center like Unity Anacostia. On the other hand, specialists at the academic medical center, you can go back. Thank you. Specialists at the academic medical center, it's difficult for patients to reach them due to lack of transportation, long wait times to see the specialist, and then, of course, socioeconomic factors like childcare and the inability to take time off of work. So these four factors, coupled with a lack of coordination between specialists and community health centers, as well as cultural and health literacy barriers, all contribute to major barriers to care for specialty care specifically for the patients that we care about here at Unity. You can go to the next, thank you. So what we did for the last 3 years now was we believe that we placed a telemedicine unit at Unity Anacostia to make our specialists available via telemedicine. We think we would, number one, bring these specialists to the local clinic to eliminate the need for travel by patients. 3, reduce travel costs for patients to visit the specialist. 4, reduce no-show rates by offering weekly appointments at a regular time that they're scheduled, usually after their primary care appointment. And then 5, it would obviously enhance care coordination between patients, their primary care doctor, and their specialist at the MFA. So in this photo, you can see our setup. This was actually in one of the clinic rooms. That's a permanent fixture. And we have a screen there, with inside that box, there's a digital otoscope and a stethoscope that can share audio via HIPAA-compliant secure video chat software like Zoom. It's not very sophisticated. We wanted to see if we could provide quality telemedicine care at a high value with very low cost. You can go to the next slide, please. So what are our outcomes? We were firstly looking at hypertension, diabetes, and kidney disease. We have 3 metrics for hypertension we were following to make sure that 50% of our patients achieved them. And we did meet that goal with 77% of our patients meeting their blood pressure target. Our diabetes results are still pending. We are still doing a lot of analysis on our data. We worked with 114 patients in these 3 years with hundreds of visits. So multiple per patient usually. Kidney disease as well is hard to, our tentative results for now indicate that only 16 patients, 24%, had no increase in their creatinine, which is somewhat to be expected for renal disease because it's a progressive condition. And what we can show with our initial results is that this care is at least equivalent to the value and the quality of care with consultation on site. That was our number one proof. We're also going to look at utilization metrics, which I'll mention in the conclusion of this presentation. We also followed satisfaction results. It's kind of hard to see but you can see that we pretty much were examining people's satisfaction with the video visits. And all of the responses here were 90% agree or strongly agree to these questions here. The two that stood out were highlighted in blue, where number one was, does this telemedicine consultation specifically make my health better? 70% of people agreed to this, indicating, like I said, that our care is at least equivalent to that of standard specialty care. And then number two was that people, 70% of people trusted the equipment. Obviously, as we all are very well aware of, there's a lot of complications using telemedicine during these COVID times. So it also affected us sometimes with technical difficulties with the stethoscope, for example. But still, it's a good data that we have for satisfaction. So to conclude, this is the first of its kind, this program, to our knowledge, in the DC area. So we had to explore the rules and translate them into practice. Like I said, our outcomes show that telespecialty consultation can provide care that is likely not inferior to the traditional approach. What are some challenges we faced? We faced interoperability challenges with the EMRs being different in each institution. We had to use a hybrid system called P2P for some information and fax the other information. So it was a big issue of discomfort for us, and that's something that needs to be worked on if we're going to really go forward with telespecialty care in the future, especially from COVID. Our training was very well received and definitely improved interactions between providers and patients. And I think I wanted to mention one thing about the pandemic. It has really put our study in a different light. Like I mentioned, CMS waivers have now allowed patient care from home. So even coming to clinic is now deemed as a major barrier to care. It really remains to see which waivers will become permanent, providing some long-term implications for this project. And like I said, we're doing a lot of analysis down the road. We're working on further analyses, including healthcare utilization metrics and looking at our no-show rates for our patients to see if they vary between regular specialty care and telespecialty care. So I know I went a minute over, or 2 minutes or so, but if anyone has questions, I will.
Okay, so we have several questions. So I'm going to read them loud. We have here a question about a specialist. What kind of a specialist are they seeing for HTM?
So, yes, Dr. Miller actually answered, but we had 3 providers from the MFA. We had a nephrologist, a cardiologist, and an endocrinologist. So that was a really solid team of providers that kind of encompassed a lot of the needs of the patients at Unity. Our cardiologist actually started a little bit later on the project, so we think that if we were to increase funding and maybe make this more of a permanent fixture at Unity, we would have a full cardiology service, because we really mostly focus on lipids for those patients. But those are the 3 metrics we followed, and we did not follow lipids.
We have a question about pediatrics. Pediatrics specialty is in the works?
So we did this grant through Care First, and I don't believe, it was an adult study. So since this is research, we have to stick to the rules. And no, we did not include pediatrics in our initial analysis, but I don't see why it couldn't be used. Children now are very frequently exposed to telemedicine and teleeducation, so they're actually arguably really good candidates for this.
Here we have a suggestion about some possibility to have the PCP with the specialist and how that would be very helpful. But of course, there is a question about billing.
So if I understand it correctly, it's that the specialist would join the PCP or call in during their PCP visit. I can see how that could be challenging for patients, because patients would get information from 2 different sources at the same time. However, I don't see why our method didn't work. We actually had the providers, for the most part, the patients going to their primary care appointment, and then they were scheduled for their virtual visit right after. So that was how we kind of navigated that. without making it too much of a synchronicity issue, because we're having someone call in and there's always, 1 or 2 or 3 minutes before you can before you can start, and it's very hard to start at the same time with people who are on site and online.
And in order to keep us on time, I'm going to mix the last 2 questions into one, and maybe you can address it in 30 seconds. So we keep this on schedule. Dr. Miller is asking if they can see card or nephrology for HPN care, and how is the best way to refer patients to you?
So the way patients were, so Dr. Miller was actually answering a question, and she did really great answer, so thank you. So how did the providers refer patients to us? It was done through P2P, which was that bridge between our 2 EMRs. And we found that to be sufficient for the course of this study, but it definitely needs work. There needs to be a way, eventually there's going to be some sort of universal EMR that we all use, where referrals are very streamlined, but there needs to be better streamlining. I agree. And for the purpose of this research, it was done through a weird way that's not typical.
And here I have 2 comments, one saying you are doing great, and another one saying that it's a great initiative, and it's frustrating not to have more coordinated care. So thank you so much for sharing your experience.
Wonderful. So many of you already have some idea who are on the call about what this quick presentation will be. Maybe I can share a little bit about a slightly different perspective on some of the research. So next slide. For those of you who may not know me, I'm Robert Czar. I am a pediatrician based at Cardozo, and am now a co-principal investigator on a NIH-funded study. It's a randomized, and we initially partnered with RAND Corporation. We continue to partner with RAND, but our principal investigator has now shifted over to Kaiser. And so we have this sort of 3 organization-wide national team that is looking at the effectiveness, essentially, of prescribing nature at Unity in a clinical setting. Next slide, please. So why do this in the first place? We have, in this country and also around the world, many nature or park prescription programs. In this country, there are somewhere in the order of about 80 to 90 programs, and many now around the world. Some countries actually have institutionalized it as a national health service component. And the big question is, despite the fact that we have 40 years of research looking at the benefits of spending time outside, we don't have enough experimental studies, particularly looking at the prescription itself. Like, does the prescription in fact confer an improvement in health? So that's what we're thinking is our hypothesis. We're hoping that's what we'll show. Randomized controlled trials are a gold standard, and there has never been one quite this large that we hope will inform whether programs like these here in our country and around the world should be expanded. Next slide, please.
Next one.
Next slide, please. Yes, thanks. This is what the study design looks like. We had submitted 3 proposals to the NIH. The first and the second were a bit more complicated and included all ages. But on the third try, we decided from the reviewers' comments that it would be better to simplify the design. So it's really quite simple. It's from 6 to 16 years old. There are 2 groups, and there's an intervention group, which is receiving a nature prescription during clinical visits, and then there's the control group that receives care as usual. Next slide. And this is really what it looks like in terms of a quick little screenshot. Once a patient and a family have been recruited and enrolled, once they get their baseline accelerometry data, and it's good, it's valid, then that participant gets randomized into one of these two groups, which then appears as a global alert in ECW. So for those of you child health providers I have trained personally, you'll see these start to pop up in your patient's charts. So very important for everybody, as we have now already begun recruitment and enrollment back in April of this year when the pandemic was hitting us hard, which slowed us down a little bit in terms of getting up and running. But now we've got about 140 participants who've been enrolled, and 66 of those have had good baseline data and have been randomized already. Next slide. So the responsibility of the provider in this randomized controlled trial is actually pretty streamlined. And the most important thing is that providers know whether a patient is enrolled or not by noticing the global alert and making an effort to prescribe nature if in fact that patient is a participant and enrolled in the intervention arm, which was labeled as NIH study green. So that's really a very simple design in that sense. In terms of the study team, we've got, as I mentioned earlier, accelerometry. So we're monitoring moderate to vigorous physical activity. We're asking participants to wear an accelerometer for 7 days at a time on 7 different occasions. So at baseline, at 3 months, 6 months, 12, and 24 months. When they get consented and enrolled, the child who is the participant or adolescent then completes a survey, and that survey is also repeated at those subsequent 4 measurements at 3, 6, 12, and 24 months. We were planning on doing, not quite yet, Adriana, so if you go back. So we were planning on doing some cognitive function testing, memory testing, as it relates to the literature in the last couple decades, especially on kids with ADHD. We needed to use an iPad face-to-face with participants. So that's been put on hold for now. And then the last thing, of course, is we're going to be mining a great deal of data from ECW in terms of body mass index, triglycerides, cholesterol, A1C, and the like. Next slide. So logistics, we're looking at recruiting about 1,000 patients from 6 to 16 years old. We initially thought we might be able to do this at one site, but have realized that given we have a refusal rate of about 30%, we are expanding to the other 8 community health centers. So we have 9 community health centers so far that we think are going to be key players in recruiting and keeping these participants enrolled. For us to have the power that we think we need to have significant results, our power analysis showed we needed about 1,000 patients. From very preliminary data, it does appear that our participants so far are more sedentary than we predicted. So we might do a reanalysis of the power just to bring down this number to maybe even as low as 500 participants, 250 in each arm. So it's possible that we might have some changes to our analysis in that sense. We have 3 bilingual research assistants, 2 based in California in Kaiser, and 1 right here, Claudia Amaya, at Unity, who are doing the recruitment, the consenting, the enrollment, administering the surveys, making sure they get their accelerometers, and getting them back. Next slide. These are the kinds of measures that are criteria that we call for a patient to be an eligible participant. So they have to have one of these following diagnoses. And these were chosen primarily because in the scientific literature up until now, these are areas that have shown improvement in terms of health outcomes by spending time in nature. So the question became, let's see if we can use these particular criteria to enroll patients. They cannot have had a park prescription or a nature prescription prior, and we're limiting this to only one participant per family. Next slide. So what have we accomplished so far? We've have a study protocol that has been approved by an institutional review board. We've developed a study team, as I mentioned, 3 bilingual RAs. We have a program manager, a data analyst, statistician as well, who's one of our co-PIs. And because of COVID, it's changed many things that we do, including research. So the NIH restricted our having any face-to-face time with participants and their families. So getting accelerometers to them and was becoming a huge challenge, and we could not mail them because they were getting lost in the mail, and each one of these is over $200. So we actually had to add a delivery driver to our team, which is also an added expense. But we seem finally to have some success with this, and we're on each run, we have about 10 participants either being delivered or picking up an accelerometer. We only have about one no-show per session at the most these days. And then we have, as I mentioned, I'm a co-PI. Bing, our statistician, is another PI, and Deb Cohen is our principal investigator. So we started in April, and as I mentioned, we've now randomized patients, 66 patients, into one of those 2 groups. And our next steps are obviously to continue recruitment and enrollment over the next 4 years. It's a 5-year study. We'll have a midway analysis, of course, of data. We might have an analysis even earlier than that, depending on what happens with the difference between these 2 groups. And then, of course, we'll have a final analysis and publications. So,
thank you so much. Let's see if there are some questions. I don't see any questions in the chat, which is really good for us because we're a little bit behind time. So, Dr. Sarr, congratulations. I'm just going to ask one question regarding any changes to the study design in light of COVID, in which many people became more sedentary because of the social mandates to keep everyone at home, and if there are any adjustments to the study design because of that.
Well, we've decided to continue with the study despite the increased barriers for our families at Unity to go outside, and in some ways I think it'll actually give us results in a more striking way than it would have had we not had COVID. The NIH did put out RFPs for supplemental funding, and we have applied for it. And one of the things that we've applied for is to study not just in pediatric patients, but in the adult counterparts and their families, whether these patients in the treatment arm and the intervention arm might have a mitigating effect of nature by virtue of this park prescription on other added stresses as a result of COVID. So if domestic violence has gone up, if decreased care has gone up, if unemployment has gone up, if these measures have increased, the question that we applied for funding was, why not study and see if in at least the treatment arm, nature might play an even bigger role in our families' lives, in our patients' and clients' lives than it did before.
Dr. Sarr, we look forward to having updates at our upcoming poster days at Unity. It looks like we will have a lot of progress to learn and a lot of the lessons learned from the study as the study continues.
Great. Thanks so much for having me.
So this was just a brief kind of summary of a little small QI project we did at Anacostia, and I think many other health centers did them as well. And this is part of the Million Hearts goal that Unity is participating in over the next few years. You can advance the slide. Oh, yeah. So what is the Million Hearts Project? Over 1.5 million people have a heart attack or stroke in the US every year. And deaths in some groups from these illnesses are actually on the rise, specifically those aged 35 to 64. The Million Hearts Project is a national initiative to prevent 1 million heart attacks and strokes over the next 5 years. I'm going to advance the slide. So how will this project do this? And I think this is co-funded by NIH and maybe the CDC, but in the American Heart Association might also be involved in this. But they basically have said, let's just get the basic things done that we know work, but make sure that that people are all receiving the care that we already know works. And so they outlined a set of kind of well-researched goals. And they said that their goal was to have 80% of patients aged 18 or older with ischemic vascular disease. That means typically people that have had a heart attack or a stroke, or they've had a stent placed in their heart, or they might have had surgery on the arteries of their legs. That group of patients, they should be using aspirin or another medication that's similar to aspirin or works similarly to aspirin to prevent the next heart attack or stroke. 80% of patients aged 18 to 85 with a diagnosis of high blood pressure have their blood pressure under control. Their next goal was that 80% of patients who need a statin therapy, and that's what we'll talk about today, will receive the statin. 80% of adult tobacco users will receive counseling to help them quit. That's another large risk factor for heart attack and stroke. And finally, that 70% of eligible patients who have a heart that is weak or that has had a heart attack will participate in cardiac rehab. You can advance. So the thing we worked on, specifically at Anacostia, was trying to increase the number of patients that we had who should receive a statin, trying to make sure that they actually received the statin or they were prescribed the statin. You can advance the slide. So what is cholesterol? Because I know we have, non-providers here, providers here. This is just a quick review. Cholesterol is a fat that's in the bloodstream, and it's a necessary fat. It helps us to produce, we need, it's an essential component of the hormones that our body makes. It forms the outer coating of that insulates our nerves, which allows our nerves to conduct messages quickly back and forth between the brain and the extremities. Cholesterol also helps to form cell membranes, and it also helps to transport essential nutrients around the body. The key thing to know is our liver makes plenty of it. Your liver makes plenty of cholesterol. You don't really need to eat too much cholesterol because your body is good at making it because it is so essential. The bad side of cholesterol is it's transported in the bloodstream, and over time, if there's too much cholesterol in the blood, it kind of pools on the walls of the blood vessels and kind of buries itself in between the linings of the blood vessels. And as you can see in the middle picture there on the bad side of cholesterol, you can see that sort of tan-colored lump that's forming. It's making it hard for the blood to pass. Furthermore, the blood vessel wall, we think, can get a little bit inflamed from that cholesterol buildup, and then that inflammation can lead to some swelling and some cracking of the blood vessel wall. Your blood vessels do not like to have a crack in them. As soon as a crack forms, a clot will form, and that's what ends up leading to a heart attack or stroke. Because once a clot forms, if you have a very narrow opening, it'll completely block the opening, and then blood cannot continue to pass. And so that's the downside of cholesterol. If you have too much in your blood, it's going to pool on the sides of the walls and prevent blood from flowing. So what are the statins, and why are they helpful? And the statins are a class of medications that have been around for maybe 25 years or so, and they're used to lower excess cholesterol. So while some cholesterol in the blood comes from food, most of it, as I mentioned, is made by the liver. And statins do three things, we think, to help lower this level. So they lower the amount of cholesterol made by the liver. That's the first thing. They also help to take some of the bad cholesterol out of the blood that's already there. And finally, we think they may also reduce the inflammation in the blood vessel walls that can predispose people to heart attacks and strokes. So who should be taking a statin? And there's a little bit of a gray area here, but there are three groups that definitely, where there's definitely evidence that this helps them. The first is people that are over the age of 21, and they've already had some kind of what was called atherosclerotic event. So they've had a heart attack, they've had a stroke, they've had a clot in a leg artery that's led to less blood flow in the leg and cramping in the legs. Another group, those people definitely benefit from taking a statin to prevent the next heart attack or stroke. Then also diabetic patients have a much higher rate of heart attack and stroke than the average non-diabetic patient. So in all sort of middle-aged to older adults with diabetes, we have some good data that trying to keep their cholesterol, putting them on a statin also reduces their risk of heart attack and stroke. And finally, there's a group of people who unfortunately are born with a body that just makes more cholesterol than it should, far more cholesterol than it should. And so with that group, we also now have some good data in adults age 21 or older who have ever had a fasting or direct LDL, that's the bad cholesterol, above 190, or were previously diagnosed with this congenital disorder called familial or pure hypercholesterolemia. Those groups, that group also benefits from taking a statin. Okay, so how did we increase our rate of statin prescribing at Anacostia Health Center? And I just have a picture of Xara here to just kind of remind me to tell you what we did. We selected in Xara, there's a tool where you can select your patients that are up to date on statins or they're in need of taking statins. And we found the group of patients we have at Anacostia who needed to take a statin and weren't on one. We sorted that group by providers. And then with the help of the health center director and the assistant health center director, we identified care coordinators and PRCs for each one of those providers. And we gave that list to the care coordinators and PRCs. And we asked them when we started to do telemedicine if they could call the patients, ask the patients if they would be interested in discussing this medication. And then if the patient said yes, then we put them on the provider's telemedicine schedule, and they would label the appointments as statin so that the provider knew what they were supposed to be talking about with the patient. So we did that a few times. We did it. there were some glitches. Sometimes I told them to put the statin in one place, but actually it was more useful for the providers to put it in another place. Sometimes we had to call 2 or 3 times, but eventually we did try 3 different times with each patient to try to get them. And I think even some of the PRCs even sent some letters. And so what were our outcomes from doing this? You can advance the slide. You can see that's Anacostia at the top. And at the bottom, it has the rate of prescriptions. And we got well above the 80%, which is the million hearts goal. Other health centers at Unity are also getting above 80%. I can't read all of the names here, but I think Parkside, CCNV, and Minnesota Avenue, maybe some other ones are doing well. And most of us are approaching 80%. But we were able, with concerted effort and multiple attempts to reach the patients, we were able to get to the million hearts goal. So I just wanted to take a moment to thank some of the people that made this all possible. So we have here Sashay Ball, Imani Ellis, Michelle Monroe, and then Aglitha Edwards. Those are some of our care coordinators and PRCs. In that same group, there's Annette High, Michelle Mitchell, Justin Williams, who unfortunately just had his last day with us on Friday, but was an excellent care coordinator, David Chambliss, Kim Toney, Michelle Smith, Nika Cunningham, Shai Jones, and Sheena Wheeler. Sheena did some extra work. She was the person who called them the 3rd time, so thanks especially to Sheena for that. And then also to our primary care providers who had the discussions with them to encourage them to take the medication and taught them about the medication and the side effects. Those are Akshat Vyas, Rita Adu, Khalid Ibrahim, Amanda Johnson, Marlon Mitchell, Terry Wynn, Nikki Harris, Aisha Corbett, Olaide Akande, and Kara Moss Murray. So thanks to everybody. And I'll just mention, there are still the one group that we're having trouble with at Unity are the people that are over the age of 21 and have an LDL above 190. So Ryan Buckles had mentioned that he thought I could send a list to individual providers to just let them know who their patients were that still met that category. So if you see a list like that from me, it's just to encourage people to continue to work on this project, because I think Unity is doing very well, but I think we can get all of our centers up above 80% in the next few months. Thanks.
Thank you very much, Abby. I don't see any questions. Yes, Sarah, the forum is yours.
All right, so I'll be presenting a literature review and a case presentation of drug-induced gingival hyperplasia, specifically caused by the drug nifedipine. Next, please. Just a small background about the drug itself. It's a type of a calcium channel blocker that's commonly used for hypertension and cardiovascular conditions such as angina. Studies have shown that, in particular, it's effective with the African-American populations. When they've ruled out all the other factors, and they're not really sure why, but it has to do with some pharmacokinetics and some genes in the DNA. But it does have low clearance in the bodies of, especially the African-American population. As we know that a lot of our Unity patients suffer from hypertension, and a lot of them come from an African-American background. Therefore, it's not uncommon for us to encounter patients who are on this drug. Usually, it's communicated to the patients the systemic side effects, which include flushing, dizziness, swelling, and lightheadedness. But less commonly, I've noticed is that it's communicated to the patients about the oral side effects, which is gingival hyperplasia. It's also important to note that in patients who have had a kidney transplant, it's often prescribed along with cyclosporin, and the combined prescription of those two drugs causes even a bigger overgrowth of the gingiva. Next, please. Okay, so gingival hyperplasia itself is a condition that involves the increased size of gingival tissues, and it's often indicative of a disease condition. It can become a problem when it affects speech, eating, and also aesthetics. There's different classes of gingival hyperplasia. Some of it is inflammatory, drug-induced, which is what I'll be focusing on today, caused by specifically groups of drugs, anticonvulsants, immunosuppressants, and calcium channel blockers. It can also be related to systemic diseases or conditions like pregnancy, puberty, leukemia, and also neoplastic, a class of gingival hyperplasia that involves benign and malignant gingival tumors. So here I put for comparison a healthy gingiva versus one that is hyperplastic. If you can compare the contour, you'll see that in a healthy gingiva, you have a nice pink translucent color with a scalloped knife edge margins. The size corresponds with the surrounding dental elements, and the texture is smooth to minor stippling. We compare it to like an orange peel, for example. On the other hand, hyperplastic gingiva tends to be puffy, irregular in shape, and it's enlarged, as you can see. It's often firm to touch and has a lobulated appearance, and we compare that to a mulberry, for example. It's often painless unless it's accompanied with an inflammatory process, but often it's painless and patients don't notice until they look in the mirror and they see that enlarged gingiva. Histologically, you could see an increase in infiltration of fibrous plastic cells and inflammatory cells in general, like plasma cells and fibroblasts. There's an increase in vasculature and dense collagen fibers. Also a thickened layer of epithelium. Next, please. Pathogenesis, we don't have time to go into all the details, but there's a series of deactivation of certain enzymes that cause decreased degradation of connective tissue, and you end up with a large accumulation of connective tissue cells like fibroblasts and plasma cells that cause the overgrowth. Next. For the management of this condition, we have two routes. There's a non-surgical and there's a surgical. We usually prefer to start with the non-surgical as it's less invasive, and then we reevaluate. That usually involves a discussion with the physician regarding interruption of the medication or modification of the dose. I've seen some studies that indicate the isradipine is a different drug that can sometimes substitute nifedipine in some cases, and it doesn't show that gingival overgrowth. So sometimes substituting nifedipine with another antihypertensive medication, that alone can help reduce the symptoms. Usually we do treatment plan scaling and root planing, which involves removal of plaque and calculus buildup on the teeth, under the gums and over the gums. With these patients, because they do have larger pockets, they tend to accumulate a lot of buildup under the gums, which is difficult for the patient to clean. Therefore, we consider scaling and root planing to be a gold standard for those patients. And that, of course, is followed by good oral hygiene at home. And usually with that alone, studies have shown that symptoms can resolve, and within a couple of weeks of just stopping the medication, the patients can see a notable decrease in the gingival size. But in some cases, when that doesn't happen, we have to proceed to the surgical excision. And there's two different methods. There's a traditional surgical gingivectomy, which is the removal of the extra tissue by surgery, or now there's laser treatments that can also excise the extra tissues. However, if the medication is not altered or changed, if the patient stays on the same dose, then there's relapse that can occur. So now I'm going to share one of the cases that I encountered at Unity. This is my patient. She is a 57-year-old African-American female with hypertension. She came to Unity in 2011 when she was prescribed nifedipine, 60 milligrams once a day. She's also on lisinopril, so there's a combination of those two drugs. She's a non-smoker. She has pretty fair oral hygiene. And when she came in, her symptoms were, she said, "I think my teeth are shrinking." As you could see here, the enlarged gingiva, the stippling, and her teeth look pretty, she doesn't have that much buildup, which is, I'm surprised. Her gingiva was kind of firm to touch, pale pink. It's not red and purple like I've seen with other patients, and that's partly due to her oral hygiene. As studies have shown that increased plaque and calculus can increase the overgrowth and the inflammatory process. This is her dental chart. She has pretty fair teeth for her age. Some caries are present, some root tips, and some missing teeth. She also has a grinding habit, which causes the teeth to look shorter than they usually should be. This next, please. Next is a radiographic, just an overview of her oral cavity. She has pretty decent dental dentition. Some root tips again are present. Not a lot of, this is, yeah, close-up of the X-rays. You can see some minor attachment loss, which clinically presented with bleeding on probing and some deeper pockets that were about 4s and 5s. She does have, you could see on the bite rings here, some mild to moderate calculus under the gums, which is understandably harder to clean because the brush setting doesn't get underneath there. I've reviewed her X-rays from 2011. These are the most recent ones, and it doesn't seem like she's lost a lot of bones between 2011 and now, which is partly due again to her good oral hygiene, and her condition is mainly due to the medication that she's taking. Next, please. So for her periodontal treatment plan, we discussed the ideal treatment, which would be to have, I referred her to her PCP for a discussion about an alternative medication. We had planned for full mouth deep scaling and root planing. And then we were going to reevaluate after 3 months. If the gums hadn't shrunk, then we would send her to a periodontist for surgical or laser excision. Then we'll do a 3-month recall after that. However, due to the finances and patient compliance, that true accepted treatment plan that we went with is just a regular prophy with some prophylaxis, is just a superficial above the gingiva cleaning and the fluoride treatment. She couldn't afford, unfortunately, a deep cleaning, which is a scaling and root planing, but we did do localized deep cleaning in those areas where I saw radiographically calculus between the teeth. That followed by an antiseptic mouthwash and excellent home maintenance as encouraged, and 3-month recall. This is what we ended up doing for her, and she's been stable since then. For conclusion, this is an excellent example of where physicians and dentists can work together for the benefit of the patient. My advice for the physician is to consider the systemic oral relationship when prescribing certain medications in these drug groups. and if possible, alter the dose of nifedipine or combine it with another drug, or I'll try different medications before resorting to prescribing that specific one. For the dentist, always be alert for when you have a patient that presents with this condition. Educate the patient about their condition, because most of the time they don't recognize that it's because of a medication that they're taking. They just come and say, I have bleeding gums, or I don't know what's wrong with my gums, they're puffy. So you should definitely educate the patient about that relationship between the medication and their gingival health. We should always advise the patient to never stop the medication on their own, but to first consult with their physician, or we could send a direct referral to their PCP. We should always encourage excellent hygiene at home and frequent recall visits, and patients with this condition should have a cleaning at least once every 3 months. Thank you.
Excellent. Thank you so much, Sarah. Let's see. Here I have some questions. So let's see. First, a lot of excitement about this presentation, a lot of excellent dental presentation. I have here a question regarding, do patients experience gingival hyperplasia from all calcium channel blocker like amlodipine or just nifedipine?
From the research that I've made, I have seen some studies which show gingival hyperplasia with amlodipine, but for me personally in clinic, I've seen numerous patients on amlodipine. I haven't seen it affect the gingiva as much as nifedipine specifically does. There are some common ones that stand out, like in the antihypertensive medications. Nifedipine is one that definitely stands out, causing gingival hyperplasia. In the anticonvulsants, for example, phenytoin is another big one. I've seen patients on phenytoin come with the same condition. So there's definitely, you can have patients get this condition from different medications, but those certain ones, there are certain ones that cause it more than others.
And have you seen reversal of symptoms after stopping the medications?
I haven't seen it myself, but yes, numerous studies have shown that even just stopping the medication alone, patients come back after a few weeks for reevaluation, and you could tell notable difference in the size of the gingival health, which is fascinating.
Yes. I want to echo the comments praising this presentation. Great presentation from William, from Cecilia, from Andrea. It's very exciting. Elaine also, Abby, Cassandra. I think we are not accustomed to hear so much about the dental health of our patient population, and this is fantastic that we are beginning to learn more about the work that is being done. Here we have a question: did you find a specific range or a specific range of concentration of nifedipine contributory to the hyperplasia? So it's probably about the dose, if I understand this question.
I haven't looked specifically at the correlation between those and the effects of the medication, but I did come across studies that have shown even just a decrease in dosage can cause a decrease in the display of or the amount of hyperplasia that can occur.
And Dr. Hammond is joining all the clapping and excitement about the presentation here. So thank you so much, Sarah. This is a very exciting presentation.
Hello, my name is Tamara Robinson. I'm a medical assistant at Unity Healthcare, Parkside location. I will be presenting why CAT and MAIS do the vaccine count. A little background about this is like during one point in time, our nurses performed the weekly vaccine count as well as the data loggers and the reports for the health center. In total, there was like 3 nurses responsible for the accurate vaccine count and the data logger upload each week on each floor in a timely manner. At times, nurses had to ensure all vaccines were delivered and received to their sites, as well as assisting with the workflow on the floor. In addition to like doing injections such as like flu shots, any other procedures that the nurses or the doctors order that we cannot do, patient educations and emergency protocols, just in case like we get a EMS patient or anything like that. Next slide. So some of the methods was basically like the inmates took on the task of being trained to learn the role of counting vaccines, also uploading the data loggers that will assist with the workflow to allow the nurses to be more available to execute nursing functions. When vaccines were delivered, inmates became responsible and reliable to make sure they would be located and stored properly in the event that the nurses wasn't available. Like sometimes the nurses could be doing like other things like patient education, nurse visits, vaccines, or helping other inmates on the floor, so they weren't able to like get the vaccines in a timely manner. Also, they probably wasn't able to help us on the floor when it was like a lot of things going on. Inmates also began to upload our data loggers and submit the reports. So basically with the data loggers, we just basically uploaded them with the reports, the front pages, to the system in a timely manner and things like that. Next slide. I think you skipped the slide.
This one?
No, I think it's one before that. Let me see. Yeah, it's one before that. That's fine. I mean, we could probably skip that slide and just do this one. Are you able to catch the slide before that?
Is it the one that says methods?
Okay, yeah, so that one right there. So basically, that's the picture of our data loggers and our refrigerators. So in this picture, it shows the data logger with like the accurate or the time frame that the data logger say at the time. So that's actually accurate. It also have like a check mark on this to let us know that the data logger is uploaded and is properly running for the vaccines. Also, this basically shows us an accurate time frame because the data loggers is good anywhere between 36 Fahrenheit to 46 Fahrenheit degrees, if I say. I already did that one. Yeah, so you gotta go the other way because I already did that one.
Next
Do we need to go to the next one that says results?
Yeah, so you can pretty much go to that one. Yeah, so basically, this is basically, again, like we said once before, our nurses became more valuable to our patients. And results to that, by inmates committing to learning a new skill, it assisted our nurses with assuring a positive and productive clinical flow. It allowed the nurses to conduct more patient education. Also, the more clinical assistance for our nurses for patient care. The nurses also was able to manage and perform more nurse visits, and there is more freedom and availability to help with house problem solving and procedures. That was this. You can go to the next slide. So basically, before I get to the question, comments, and concerns, I will tell you everything in conclusion. So in conclusion, it became a better workflow for everyone. It was a new skill set that the inmates could learn, also to potentially develop new skills, and also to teach the inmates, who wanted to assist as well. It gives the inmates insight on what roles and responsibilities that the nurses have to carry. And it also gives the inmates privileges to become more marketable in the healthcare field. And that says, like, if they were at other sites or other nurse managers wanted other inmates to do it, we just basically give them, the insight on being able to count the vaccines and do the data logs. Any
Thank
questions,
you so
comments,
much.
or concerns?
Here there is a lot of congratulations. Great presentation. Very timely topic with our
Yes.
season coming up.